have renal failure and they're not activating it because it has some other pleiotropic effects as a hormone, and there is some extrarenal 1-alpha hydroxylase activation of that. And so it does improve patients' EQ, it's not effective alone. So if you're going to give them inactive vitamin D, you should also think about giving them active I think of these in practice as two very distinct indications, right? If someone has vitamin D deficiency, again, which is this, right? Their serum, 25 OH, vitamin D is less than 30, they get vitamin D. They get cholecalciferol or ergocastiferol, right? Those are the precursors, those are inactive. It's just treating this deficiencies. If they have hyperparathyroidism, I don't use these drugs for that. I use tuflotriol, doxycycline, or it could be on them both. That's okay. Take them distinctly. Calcidiol is really only used in 3 and 4. So that's the location. Questions on this? So anemia, we tend to not use oral iron in dialysis patients. It's not effective aside from ferric citrate. It could be trialed in CKD patients, but it's often limited by poor bioavailability, a lot of GI side effects, and some drug-drug interactions. Ferrous sulfate is the most common one used. The standard dosing is 1 tab TID. There's new recommended dosing to use spaced out dosing. So instead of giving 1 tablet 3 times a day, give 2 or 3 tablets once a day or every other day. That reduces the hepcidin increase. That's not yet mainstream, but that is something that's helping the company. Polysaccharide iron is more expensive and 100% iron, so that's the one benefit. It's only once a day, but remember, it doesn't change the bioavailability. It's still pretty cool. Lots of drug-drug interactions that need to be concerned about because of the endocrine and GI tract, so the administration should be separate from the meds by 2 hours. And then IV iron, which is the go-to gold standard for the dialysis population, should be used in patients that have a transferrin saturation less than 30% and or ferritin less than 500, since those are the targets for those values for the KDIGO 2012 guidelines. And those targets hold for all CKD patients, not just dialysis patients. And so the target dose in someone that has a TSAT less than 30% is 1 gram of IV iron. That's elemental iron. All of these are listed in doses that are elemental iron. Ferrogluconate or Therlacet and iron sucrose or Benefer are the 2 most commonly used iron products. So they're dosed either 1.5 or 100 milligrams at a time, 8 or 10 doses respectively to get your 1 gram target dose. Intravenous ones are better because we guarantee that the patient gets them, we guarantee bioavailability, and they don't have those drug-drug interactions or those GI side effects. They're worse because the side effect potential is more severe, right? They can have side effects, they can include infusion reactions, which could include things like hypertension, tachycardia, shortness of breath, and be as severe as anaphylaxis. So that's very rare with these newer products, but it's still a potential. So the side effect profile, while the side effects are more rare, they're more serious if they occur. The infection risk with IV iron is a theoretical one, but one that is often touted clinically to avoid IV iron in patients with an active infection. It suppresses white blood cell trafficking. It also provides food for bacteria, and so both of those reasons we have to think it would worse in active infections. Those are the goals. Again, ferritin above 500, TSAT above 30% for the KDIGO guidelines. That's what I want to do. ESAs, so there's epoetin alpha, which is the shorter acting one, darbepoetin alpha, which is the longer acting one. And now there's 2 other ones. There's pegylated methoxy, epoetin beta, I think it is, which is Nucera. That's a very long acting epoetin. And then there's the Retacript, which is a biosimilar to epoetin alpha. The main difference here is half-life. So epoetin is dosed 1 once a week or 3 times a week. Darbepoetin is dosed every 2 to 4 weeks. And then Mircera is dosed every 4 weeks. Takes 4 to 6 weeks to see a reasonably steady state change in the hemoglobin, and that's how long we should wait until we make changes in the patient's dose. The goal hemoglobin in these patients, if their dialysis is 10 to 11, if their CKD, the goal is 10. The hemoglobin change, the rate of change is important. If it changes too much, too fast, we need to do something about the dose, which is why we check hemoglobins about once a week or once every other week as the doses are being adjusted until they've reached a stable hemoglobin. If the hemoglobin goes up by more than 1 in 2 weeks, then we need to address that. We should either reduce the dose by 25%, which our dosing increment changes are always 25% up or down, or you should hold the dose if they exceed the target. So this was the old slides, which says approaches 12. This should say 11, right? So the target is 11. So if the hemoglobin exceeds 11, you want to hold that dose until it comes back below 11. If it doesn't exceed 11, but it goes up by more than 1 gram in a 2-week period, then you want to cut the dose by 25%. After your 4 to 6 weeks, if you're not yet at your target, that's when you increase the dose by 25%. Right? You shouldn't be doing dose increases any more frequently than every 4 weeks. Right? You want to wait for that red blood cell response to change. ESA resistance is often caused by iron deficiency, use of ACE inhibitors, deficiencies in folates or B12, or other inflammatory diseases, infection, malignancy, trauma. Side effects of these drugs are pretty extensive: hypertension, hypercoagulability, increased risk of thromboembolic events, cardiovascular events, stroke, mortality, true red blood cell aplasia. The list goes on. This is why we have a very narrow hemoglobin target, right? So a lot of these serious risks like stroke and MI and DVT, that's when the hemoglobin target was higher, and that's why we reduced the target to 10 to 11. So that lower target helps to mitigate this risk. It's still not gone, it's still there a little bit. Pure red cell aplasia is very, very rare. It basically happens when your body develops an immune reaction to the exogenous EPO, and that removes all of the EPO from your circulation, including any endogenous EPO you're making if you're no longer able to produce red cells. Those patients become transfusion dependent and go very, very long. Black box warnings for tumor progression, hemoglobin's above 11, and DVT prophylaxis in the perioperative period. Very important. Goals, we have 10 to 11 is the goal hemoglobin. Yeah, so contraindications to me are really active malignancy with expectation of cure, a very high risk of CVA, or hemoglobin above 12 is true, probably above 11 or 11